All right, good afternoon, everyone, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Clay Bryant, who will be taking the next 3 Grand Round sessions to present on NHSN data. For this presentation, Clay will be discussing generating TAP reports. At this time, I'm going to stop sharing my screen and turn the presentation over to Clay.
All right, so is everyone able to see my screen okay?
We can see it.
All right. So good afternoon, everyone. My name is Clay Bryant, and I currently serve as the NHSN program lead for the Kentucky Department for Public Health, Hospital-Acquired Infections, and Antimicrobial Resistance Prevention Program. In recent years, HAIs and other patient safety issues have continued to challenge our healthcare systems. And the National Healthcare Safety Network, or otherwise known as NHSN, is one of the most widely used systems that we use to track HAIs, and it stands as a pivotal tool as it provides us the means to collect, analyze, and disseminate valuable healthcare-associated data. These data can then be used to make informed decisions and implement targeted interventions. So the primary objectives for our discussion today is to first describe the TAP strategy with a focus on target, which is the T in TAP, as well as review the methods for calculating the SIR and explain the CAD. We will also describe the differences between the SIR and the CAD, as well as lastly, we will talk about how we can generate TAP reports within NHSN. So first, starting off, what is the TAP strategy? So the primary aim of the TAP strategy is to use available data to prompt action. We know that data, when collected properly and accurately, as well as analyzed, it holds an immense potential. In our case, the potential lies in driving proactive responses to mitigate the risk of HAIs. By analyzing the data generated through NHSN, we can identify patterns, trends, and potential problem areas that might go otherwise unnoticed. The TAP report also serves as our eyes into the gap of infection prevention. These reports lay bare the areas where our infection prevention measures might be falling short, thereby giving us a roadmap for potential improvement. Think of these reports as a diagnostic tool that can help us identify potential weaknesses. And the true value of the TAP strategy really shines through is when we translate these insights into tangible infection prevention strategies. So these strategies are often rooted in evidence and driven by data, and this enables us to take meaningful steps towards closing the gaps that we have identified. Whether these gaps are refined using or refining our protocols or enhancing our training, the TAP strategy really empowers us to implement targeted measures that matter. So now let's break down the steps involved in identifying our targets using the TAP strategy. This is where we can transform our data into action. The initial step in the strategy begins with the generation of the TAP reports, which is the process that focuses on tapping into the available facility level data within NHSN. One of the primary metrics in the TAP report is the cumulative attributable difference, or otherwise known as the CAD. This is a powerful metric that allows us to identify locations within our healthcare network or facility that are facing an excess burden of HAIs. By zeroing in on these locations, we ensure that our efforts are directed to where they're needed most by maximizing the impact of our interventions. Generating TAP reports and identifying high burden locations is just the beginning of the TAP report or the TAP strategy. The true strength of the TAP strategy lies in the actions that follow. Once we've pinpointed the areas of concern or the areas with an excess burden of infection, it is crucial that we actively engage within these targeted locations. This engagement can take various forms of focused prevention efforts that involve collaboration, training, resource allocation, and implementation of tailored strategies to counter the elevated risk of HAIs in those locations. So TAP reports incorporate the data that you, as well as your colleagues, have entered into NHSN for select HAIs. This data becomes the foundation on which we identify specific locations within a facility that is experiencing disproportionate or excess burden of infections. The important aspect of the TAP report is the concept of translating a targeted SIR into a tangible numeric goal. This step is essential as it bridges the gap between abstract metrics, such as the SIR, into actionable objectives, which would be the CAD. By giving our goals a quantifiable form, we are better equipped to communicate, track our progress, and make informed decisions. The TAP report provides more than just numbers. It provides a purpose. It serves as the union for our collective efforts as we aim to prevent HAI. Therefore, with a clear and specific goal in mind, our healthcare teams are better motivated and equipped to implement the strategies and interventions that are needed to achieve these goals. So TAP reports are really driven by data from a variety of different data sources, starting with our annual surveys that we're completing every March of each year, which these are used to adjust for the expected risks within our facilities, which is then used to produce a predicted number of HAIs, as well as we standardized infection ratio, or SIR. These ratios are calculated using the observed and predicted infections and provide a standardized measure to evaluate our infection rate. They account for patient risk factors, giving us an objective benchmark. To gain insight into specific HAIs, TAP reports integrate event-level data, such as for CLABSI, CAUTI, CDI, and MRSA lab ID events. For example, looking at the pathogens reported for CLABSI and CAUTI. The TAP reports are only available for select HAIs, which exclude surgical site infections, pneumonia events, as well as ventilator-associated events. The green check marks on the screen represent the facility types and select HAIs where TAP reports can be generated. So looking at the first row, we can see for acute care hospitals, including critical access hospitals, a TAP report can be generated for CLABSI, CAUTI, CDI, and MRSA lab ID events. Whereas if we were looking at an inpatient rehab facility, we are only able to generate TAP reports for CAUTI and CDI. Now we will do a quick review of the SIR. So the SIR, or SIR, is a metric that is a ratio of the number of HAIs observed versus the number of HAIs predicted. The SIR is calculated by taking the number of observed HAIs divided by the number of predicted HAIs. The SIR, or SIR, is interpreted differently based on the value. For an SIR equal to 1, we would say that the same number of infections were observed as predicted. For an SIR greater than 1, we would say that more infections were observed than predicted. And lastly, for an SIR less than 1, we would say that fewer infections were observed than predicted. It's important to remember that an SIR will not be produced if the predicted number of infections is less than 1. We should also take in consideration when we are looking at the predicted number of HAIs and our SIR that is produced, this is based on aggregate data from 2015. So during that time, based on the 2015 baseline, this is how many infections we would be predicted to have. Now let's take a look at an example SIR report to interpret the SIR value. So looking at the SIR output for CAUTI in 2022, we can see that more infections were observed than predicted. Therefore, we would expect an SIR that is greater than 1. Looking at the SIR, we can see that the value is 1.183. This can be interpreted as the SIR for CAUTI in 2022 is 18% higher than would have been predicted given the US baseline data in 2015. So we're going to do a quick poll real quick. So if you have your phone available, you can pull out your phone and scan the code or go to menti.com and type in the code. And I want you to answer the question really quickly. Which facility type do you assume would be able to produce a CAD value for select HAIs? Only a facility with an SIR that is greater than 1? Only facilities that have an SIR, so for example, that they have a predicted value that is greater than 1? Only facilities that do not produce an SIR, or all facilities can produce a CAD value? We'll take a moment and see what we have there. All right, so looks like we have 3. I'll give it a few more seconds to see if we get any more responses in. All right, so taking a look at the correct answer there. So this would be for all facilities, and this is a really important aspect of the CAD as compared to the SIR, as with the SIR, we do not have that value produced for all facilities, only facilities that have a predicted number of infections that is greater than 1. So as we've just observed, the CAD can be produced for any facility as long as they have a predicted value. This allows for facilities that do not produce an SIR to still have a metric that can be used to drive action and identify locations within a facility that have a disproportionate burden of excess infections. The CAD is different from the SIR, as the CAD is a metric that shows the difference between the number of observed infections and the number of predicted infections. This value is then multiplied by the SIR goal. Therefore, the CAD value is the number of infections a facility would need to prevent to meet a defined SIR goal. So we can see the calculation there for CAD, where we take the observed minus the number of predicted HAIs times that SIR goal. Now let's take a look at an example. Using the same CAUTI SIR report as before, we have 65 observed infections in 2022 and 54.944 predicted infections. We are wanting to achieve the HHS CAUTI goal of an SIR of 0.75. After calculating, we have a CAD value of 23.79, which would equate to 24 excess infections. The CAD should always be rounded up to the nearest integer, as we cannot reduce or eliminate a half of an infection. So we always want to round up to the nearest integer. Facilities can use a custom SIR goal as long as it is less than 1. The TAP report rather will automatically generate using the HHS goal as a default. So if you want to change that to a custom goal, we'll talk about that later on in this presentation. You can review the HHS goals at the link on the screen. Below are just 2 examples of current 2020 HHS goals for HAI reduction for CLABSI and CAUTI. Now that we have an understanding of the CAD metric, here is an example of the TAP report for CAUTI. 2 CAD values are produced. We have the facility CAD, which includes the total excess infections for the entire facility during the specified time period. Additionally, you will have a location CAD, which is the excess infections for each given location in the facility where HAIs were reported. Note that a negative CAD indicates infections were prevented. During the next session on September the 6th, we will review all the other variables and metrics included within this report. As mentioned, the SIR and CAD are different and serve unique purposes. First and foremost, it is essential to grasp that the CAD does not function as a comparison metric for performance, unlike the SIR. The CAD takes on a different role in our strategy, offering insights that go beyond what the SIR provides. The SIR is designed to compare the actual number of observed infections against the number of predicted infections. This comparison is adjusted to account for factors such as known risk factors, variations in the patient populations, and differences within each facility type. The goal is to offer a fair and standardized assessment of these infection rates, and that is achieved by the SIR. On the other hand, the CAD focuses on detecting the burden of excess HAIs or infections. This metric is crucial in helping us reach a predetermined SIR goal. By pinpointing locations with a higher than or excess burden of infection, the CAD helps us tailor interventions to efficiently close the gap between the observed and infection prevention, the observed and expected infections. Now that we have a firm grasp on the general concepts of the TAP report and the CAD metric, we will discuss how to generate TAP reports within NHSN. All right, so just to begin with some quick tips for generating TAP reports. So as we know, TAP reports are built on rules that influence the SIR, which specifically we're looking at the predicted number of infections. Before we run any TAP report, we want to ensure first off that all locations are appropriately mapped, as well as we want to ensure that the data set has been updated and includes the time period of interest. So it's always a best practice to go into NHSN and generate a data set and making sure the period of time that you're wanting to look at is included within that data set. We recommend always using a time period that includes at least 1 quarter's worth of data. Monthly data is typically not recommended by CDC when generating TAP reports. So how do we access the TAP report? So first, we are going to go into NHSN, get logged in, and on the left-hand side of our screen, we will see analysis. We'll then go over to and click there. Once we're into reports, we will see a list of all of the different folders for different types of reports that we can generate. We will then go into the TAP reports folder, and you will see 3 different reports, which include critical access hospitals, long-term care hospitals, as well as our inpatient rehab facilities. For this presentation, we will specifically be looking at acute care hospitals. However, for LTACs and inpatient rehab facilities, the process remains the same. So we would click on the acute care folder, and we would see the drop-down for the various types of TAP reports we can run for the select HAIs, including CLABSI, MRSA, and CDI lab ID events. So you're going to start by choosing to either run or modify a TAP report for each of the available HAI types, whether you want that to be for CLABSI, CADI, CDI, or MRSA. In this example, we are running a TAP report for CLABSI. When we select the run, it will create the automatic default TAP report in an HTML output. And that report will include the specified time frame that was identified when you generated your data set. It is suggested that you go in and modify to allow for customization of the TAP report, which can include changing the title and the format, such as including it as a PDF or an Excel. You can also filter, however, this is not recommended. You can adjust the time period for the TAP report and what data would be included, as well as the different display options. So maybe modifying our SIR goal to be a custom. And then lastly, it will allow for exporting the data set, which will pull the included data in our original generated data set. So now moving into the ways that we can generate the data set. And this will be when we go into modify the TAP report. So first looking off at the first tab, we want to first always go in as a best practice and select the show descriptive variable names. As we know, there are a variety of different variables that are included within NHSN, and some of them do not have very clear names. So whenever you click Show Descriptive Variable Names, it puts it in a way that is much more understandable when you're going through the different variables that you have selected or that are included within the TAP report. Within this tab, you can also change the title if you would like to. You can change the default format, which is an HTML, to a PDF, an Excel document, or a rich text file. But if any other format is recommended, usually an Excel document is most commonly used. Moving on into the next tab, we have the time period tab, which allows you to select the date variable that you would like to go based off of. So we have half year by month, although as we had previously mentioned, this is really not recommended by CDC to do by month, but rather at least by 1 quarter's worth of data. So we have quarter and year. And in the section below, I have some just examples of time period formats, as it is not always very clear on how to input our dates that we would like within NHSN. So those time period formats are just there for your reference. The next tab that we have over is for filters. As mentioned, this is really not recommended unless you're a group user and you have multiple facilities within your group. Suggested filters that would be recommended for group users are by filtering such as your CMS certification number, the facility org ID, or the facility type. As we can see here are just 2 examples of filters that would be used or commonly used for group users. In the top example, we have where we're filtering by facility org ID, where that is equal to whatever facility. So this would limit the report to only include that facility. And then in the other example, we are filtering by facility type, where it will only include the facilities that are of the facility type as a general hospital. Our last tab in the modification section, the TAP report, is the display options tab. As mentioned, the default output for the display is by using the HHS 5-year HAI reduction target, which we can see those on the screen as 0.75 for CAD, CDI at 0.70, and 0.50 for CLABSI and MRSA. So you can go by that particular HHS goal, or you can insert your own custom SIR goal, which must be at least 1 or less. Now, once you have completed all of the tabs, starting with the title, the filter, if you're a group user, and then lastly, with the modifications to a custom SIR goal or the HHS SIR goal, you will then go into running your TAP report. So there are a few functions that can be used when running. So if we click run, this will generate your report in the selected format that you have specified in this section of the modified report. So if you had kept it as an HTML, it will generate as an HTML file. If you click save, this will save all of the report modifications that you have made, and then under your analysis report section within NHSN, you will see this custom report under custom. And then lastly, you will see the export function, which will generate the report based on selected format with modification. So this will include as a CSV file, where it will export a direct file that you can then download. So these are all of the steps that are included in generating the TAP report and the general understanding of the CAD value, as well as a brief review of the SIR value. So I encourage each of you to attend the next session, which we will talk about using the TAP report data to identify gaps in infection prevention, as well as review and discuss the interpretation of the additional variables and metrics that are included in these reports. And I have just a few resources that are available. If you have any questions regarding the TAP report or the variables or how to run the report, feel free to email NHSN help desk at ky.gov, and we would be happy to answer those questions, as well as some additional documents that can be used for your reference when using the TAP strategy, as well as the TAP report. And if there are any questions, I will gladly take those now.
All right, everybody. Well, I want to thank Clay for this wonderful presentation, and I invite everybody back next week for Grand Rounds for session 2 of this series. Thanks so much, and